Coagulopathy, suspected as the underlying etiology of heavy menstrual bleeding based on ultrasound findings. This patient was a 21-year-old single lady who presented with heavy menstrual bleeding requiring multiple blood transfusions. Ultrasound showed bilateral hemorrhagic cysts with ascites, which had the features of hemoperitoneum. When these features were observed, I asked the patient about prolonged bleeding following minor injuries, and the patient answered in the affirmative. So my clinical suspicion was heavy menstrual bleeding secondary to von Willebrand's disease. So we invited the hematologist who thought of a thrombocytopathy to rule out idiopathic thrombocytopenic purpura. After the blood film and the full blood count and the blood film were reviewed, the hematologist made an impression of acute leukemia, most likely acute myeloid leukemia, and she requested for bone marrow aspiration, flow cytometry, and other indices. Unfortunately, the patient died approximately 48 hours after the review. Before the hematologist was invited, the attending resident doctor reported that he had vomited a chocolate-like material, which was not consistent with hematemesis. Then we knew that we had to act fast, otherwise things may get out of control. Now let's remember the figure 2011 classification of causes of abnormal uterine bleeding, the palm coin classification. Remember the one that ultrasound scan or imaging can pick the palm, the polyp, the adenomyosis, leiomyoma, malignancy, and hyperplasia. Both coagulopathy, ovulatory dysfunction, endometrial, iatrogenic are commonly not detected using imaging. But in this case, we suspected coagulopathy based on the findings of ultrasound scan, and that's why we promptly invited the appropriate specialty to review. Now, this is the transabdominal video. So, here you can see the bladder, the uterus, the thickened endometrium. Then, look at this hemorrhagic cyst. Not this ascites, and then the other ovary. So it's bilateral hemorrhagic cysts. Look at this fresh clot here. These are features consistent with hemorrhagic cysts. So why bilateral hemorrhagic cysts? Unilateral is understandable, but bilateral hemorrhagic cysts without any evidence of trauma, we need to find out the cause. Now look at this ascites. It's echogenic. So that's why we suspected hemperitoneum. More so that we have bilateral hemorrhagic cysts, and this echogenic content suggests that this could be hemoperitoneum. So you see that it's a classic hemorrhagic cyst. I think this is the first time I've encountered bilateral hemorrhagic cysts. So look at the echogenic content of the fluid collection, which is consistent with hemoperitoneum. Well, the patient was a virgin, but despite that, the pregnancy test was done to be sure that there are no pregnancy-related problems. So these are the ileal vessels. So now going to check the Morrison sponge. Here you are. You can see huge collection in the Morrison sponge. So the hypertrophy is significant. Of course, we don't expect hematoma to take up column since it's not a live tissue, as you can see here. So our learning point is that yes, ultrasound does not diagnose coagulopathy directly, but it can suggest indirectly when the findings are inconsistent. For example, you have a bilateral hemorrhagic ovarian cyst in a virgin with spontaneous peritoneum without trauma and a thickened endometrium without focal lesions. So these features made us suspect coagulopathy, and it turned out to be a case of suspected acute leukemia based on the basic laboratory investigations done before the patient died. Thank you very much for listening.